Good day, doctors. Today I'm going to start this series of short lectures in cardiology, which is specifically intended for medical residents, but also very useful for us busy medical practitioners. So this series will be entitled On the Go Cardiology. And we would like to keep the lectures very short, but very useful and practical for all of us. So to start off this series, I'm going to give a short lecture on the role of anticoagulation in COVID-19. So we know that COVID-19 is primarily a respiratory illness, but it could also cause dysfunction of other organs in the body. It could manifest with neurologic manifestations. It could cause renal complications as well as gastrointestinal, cardiac, endocrine, and dermatological manifestations. But autopsy reports and many case series have also shown that COVID-19 can lead to an increased incidence of arterial and venous thrombosis, and may possibly be one of the possible causes of morbidity and mortality among patients with COVID-19. So these patients may develop deep venous thrombosis, pulmonary embolism, and catheter-related thrombosis. Now, in this case series of 30 patients admitted at the ICU, 16 were shown to have clinical deep venous thrombosis. And in this case report by Casey et al., there was a patient with who was low risk with no travel history or comorbidities who developed pulmonary embolism. So it has been theorized that COVID-19 itself can predispose to the development of pulmonary embolism. So what are the mechanisms underlying the development of venous thromboembolism in patients with COVID-19? So we know that COVID-19 leads to an inflammatory state, and it causes endothelial injury. The endothelial injury could cause thrombin generation and fibrinolysis shutdown, leading to a hypercoagulable state. So aside from the inflammation, the patients may develop cytokine storm and lung injury, and this together with several factors such as the patient's comorbidities like underlying cardiac disease, underlying pulmonary disease. If the patient is elderly, male with obesity and cancer, these other comorbidities could lead to the increased incidence of venous and arterial thrombosis among COVID-19 patients. In this study by Ning, Tang et al., it was shown that patients with severe coronavirus disease and coagulopathy had greater mortality if they are not on heparin, while those on heparin, seen as a blue graph, they have a 28-day lower mortality if they were started on heparin. This also shows that with an increasing D-dimer level, the patients would have a greater chance of developing venous thrombosis. Now, it's very important to risk stratify patient and predict the risk of developing venous thrombosis. And for this, One of the recommended prediction score for developing venous thrombosis among hospitalized patients is the Padua prediction score. Now, this scoring system takes into consideration the presence of risk factors such as active cancer, previous VTE, reduced mobility, the presence of a thrombophilic condition, uh, recent trauma or surgery, elderly, the presence of heart or respiratory failure, acute myocardial infarction and or ischemic stroke, an acute infection or rheumatologic disorder, the presence of obesity and ongoing hormonal treatments. So these have their corresponding scores, and the scores are added up, and if the patient has less than 4 points, they are considered to be low risk of VTE, while those who have more risk factors and adding up to a score of more than or equal to 4, these patients are deemed high risk for VTE and warrant thrombotic prevention. So I will be discussing the current recommendations for anticoagulation, and these recommendations are taken from the latest guidelines of the Philippine Society of Vascular Medicine last July. And it is recommended that hospitalized COVID patients should be categorized as either mild, moderate, or severe to critical. And it's also very important that upon admission, you request for a D-dimer, because a D-dimer of more than or equal to 1,500 nanograms per ml predicts risk of venous thromboembolism and may actually warrant prophylactic anticoagulation. Now, as a review, we categorize COVID-19 based on the World Health Organization guidelines. So those with mild disease or mild illness have uncomplicated upper respiratory tract infection with only non-specific symptoms. Those with moderate COVID-19 have pneumonia, which is not severe, and there is no need for supplemental oxygen. However, those with severe COVID-19 are those who have severe pneumonia with any one of the following: um, a respiratory rate of more than 30, severe respiratory distress, and an oxygen saturation at room air of less than or equal to 93%. Also, those who have ARDS, sepsis, and septic shock are categorized as severe COVID-19. Now, for mild illness, most of these patients usually are not hospitalized. But these patients may, for some other medical reason, be admitted. And these patients should have their Padua scoring checked, so that if they have a high Padua score of more than or equal to 4, it would still be warranted to give prophylactic anticoagulation in these patients. However, if the Padua score is less than 4, then no prophylaxis is needed. For those with the moderate COVID-19, it's important to note that these patients should ideally be started on standard dose prophylactic anticoagulation. So for the standard dose, our choices for anticoagulants would be enoxaparin. And it's very important that the dose of enoxaparin should be based on the patient's chorea clearance. So for patients with normal chorea clearance, they could be given 40 milligrams subcutaneously every 24 hours. However, if the chorea clearance is less than 30, then the dose is decreased to 30 milligrams every 24 hours. If the chorea clearance is less than 15, then it's better to use other anticoagulants such as unfractionated heparin. So it's also very important that you also take into consideration whether the patient is obese. So if the patient is obese, then you may have to also adjust the dose of enoxaparin. So the advantage of unfractionated heparin is that there is no dose adjustment for chorea clearance. So if the chorea clearance is less than 15, then this may be preferred over enoxaparin. So the usual dose is 5,000 units sub-Q every 12 hours. And for obese patients, you may also have to adjust the dose of unfractionated heparin. Another alternative anticoagulant for these patients would be fundaparinol at a dose of 2.5 milligrams subcutaneously every 24 hours. And you also have to adjust the dose if the chorea clearance is less than 30 or 30 to 50 ml per minute at 1.25 subcutaneously once a day. However, if the chorea clearance is really low, if it's less than 30 ml per minute, then it's better off using other anticoagulants. For patients with severe to critical COVID, especially those ICU patients, we give intermediate dose prophylaxis. So you have to take note of the following doses for intermediate dose prophylaxis. You could use enoxaparin. If the chorea clearance is more than 30, then you could give 40 milligrams subcutaneously every 12 hours, or adjusted to weight at 0.5 milligrams per kilogram every 12 hours. If the chorea clearance is 15 to 29, then reduce the dose to once daily. However, if the chorea clearance is less than 15 ml per minute, then it's better to use an unfractionated heparin at 7,500 units sub-Q every 8 or every 12 hours. Now, if the patient has suspected or confirmed venous thromboembolism, such as DVT in the upper and lower extremities, or you suspect or confirm that the patient has pulmonary embolism, then you have to be more aggressive with the dose of anticoagulants. So for these patients, we give the therapeutic dose of these anticoagulants. So you have to take note of the doses accordingly. You could use enoxaparin, 1 milligram per kilogram per dose every 12 hours. If the chorea clearance is less than 30 ml per minute, then reduce to 1 milligram per kilogram daily. If your chorea clearance is less than 15, then you'd better off using unfractionated heparin. For unfractionated heparin, you give initial dose of 80 units per kilogram IV bolus, and you give as a drip at 18 units per kilogram per hour. Then you target an APTT of 50 to 70, and you have to adjust the dose of unfractionated heparin based on the APTT results. An alternative would be to give an initial IV bolus of 5,000 units, followed by 250 units per kilo subcutaneously every 12 hours. So there is no renal adjustment needed if you're using unfractionated heparin. So for fundaparinol, you could give based on the patient's weight. If the patient is 50 to 100 kilos, then give 7.5 milligrams subcutaneous daily. For those with less than 15 kilograms, give 5 milligrams daily. Well, if the patient is more than 100 kilos, then you have to increase to 10 milligrams subcutaneous daily. Fundaparinol is not recommended if the chorea clearance is less than 30 ml per minute. For patients who are really obese at more than 100 kilos, then you have to increase the dose at 10 milligrams sub-Q, Q24 hours. So, what are the contraindications for anticoagulation? So, if the patient has a platelet count of less than 25 and has active bleeding, um, then these are contraindications for giving anticoagulation. Now, it should be noted that an abnormal PT, ProTime or APTT, is not a contraindication for anticoagulants. So, for these patients who have contraindication for anticoagulation, then your alternatives would be to give mechanical VTE prophylaxis in the form of intermittent pneumatic compression or graduated compression stockings. So thank you very much for your kind attention. I hope that this lecture will prove useful for us as we battle COVID-19. Have a good day and keep safe.